This is Dr. Charles Parker, and you're listening to Core Brain Journal. It's the place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street.
So welcome, everyone. We're really pleased today to have Dr. Aron Tendler here. He's down there from West Palm in Florida, and he actually has 3 offices in that vicinity. But the real interest that I have in speaking with you today, Aron, is that you are a guy who has a lot of knowledge about several specific treatment modalities that a lot of people don't know about. And so I'm looking forward to tapping your brain, having you tell me about it, because I know a little bit about it, but I don't really know as much as you do, and it's going to be a good learning experience for me. By the way, our first interview was with a patient who did not do well with psychiatric treatment. And she had years and years of suffering, medication withdrawal, and she's been writing about it vigorously on the internet for a while. And so it's interesting to bring together a professional who's doing something very specific about attempting to resolve those treatment failure issues with a patient who just came before, who was turned inside out by just treating appearances. So Dr. Tendler has 3 locations. His website is advancedmentalhealth.com down in Palm Beach. And I'm going to read a brief bio, and then I'm going to ask you to amplify on it if you don't mind. So in 2006, Dr. Tendler and his medical partner opened Advanced Medical Care, as I just was talking about, which has grown to include 3 psychiatrists, 2 psychologists, and Dr. Tendler, treats several mental health issues ranging from adjustment disorder all the way out to schizophrenia, and he conducts intensive psychotherapy for individuals and couples. Now here's where we get to where the rubber meets the road today, folks. In 2009, he began using rTMS for treatment-resistant disorders, and we'll hear about that in just a second. Since then, he's been a principal investigator and head research psychiatrist of several clinical trials, with the most recent trial investigating the effectiveness of dTMS in regards to bipolar depression, mild cognitive impairment, smoking cessation of all things, and OCD, obsessive compulsive disorder. Dr. Tendler graduated in 2002 from the State University of New York and Downstate Medical School in Brooklyn with distinction in research. 2002 to 2004, he went south down to Tulane University. A study, actually, I would ask for a clarification, internal medicine and psychiatry. Did you do a joint residency there in internal medicine? See, that's very interesting. You were already interested in both sides of it. And then he started working after that in comprehensive care and psychosomatic medicine. So on a personal note, Dr. Tendler, after all that, what would you say is the most important thing that I missed in that interview in terms of who you are as a person?
Well, in 2004, I moved to the University of Chicago, and where I trained between 2004 and 2006 in general psychiatry and in psychotherapy. Mm-hmm. And also in 2005, I did a part-time fellowship. 2005, 2006, I did a part-time fellowship in sleep medicine, and I eventually after I became board certified in psychiatry, I became board certified in sleep medicine. So, but I think probably the main thing you wanted to talk about, like you said, was in transcranial magnetic stimulation. I think that's the main area of interest for you.
It really is. And I had heard about transcranial magnetic stimulation, but I didn't know there was an rTMS and a dTMS. So could you take a moment? That's how basic I am. And you smile on that, but that's where I think a lot of people are. So could you elaborate on that for us, if you don't mind?
Well, I think the point to start with is that, the field already, when I was in my residency, so already in the 2000s, it was already, every episode of the Green Journal, the American Journal of Psychiatry, would have some article with pictures of the brain showing something along the lines of, oh, this is what the brains of people with schizophrenia are like. This is what the brains of people with phobias are like. This is how people's brains with, for example, social phobia, how they're different from the brains of people who don't have social phobia. They respond differently when you show them pictures of neutral faces versus pictures of normal faces. So psychiatry was changing already its approach or its attitude about how to view people with emotional disorders, from a disorder that was very general to a disorder that was related to function of specific areas in the brain.
Yeah.
So we were kind of functional imaging, or imaging of areas of the brain during a specific task or at rest, was teaching us of what are the actual neuroanatomical basis or targets in various diseases, specifically the ones we were going to treat later on, such as depression or maybe addiction or maybe OCD. So what are the areas that we wanted to target? And, as every psychiatrist knows, the problem with psychiatric treatment, and the problem that your patient that you interviewed, I didn't speak to or didn't hear her story, but the problem of treatment resistance is so common. It's not even like a referral case. It's just the norm. Unfortunately, the treatments we have in psychiatry, they're not like antibiotics. They don't have efficacy in like the 80 or 90%. Not like you give a drug to a patient and they have incredibly high rates of getting well from the treatment.
Mm-hmm.
We're talking about drugs that really, separate. They do separate from placebo, but really, somewhere between 30 to 40% of the people actually become well after getting a trial of a drug. And that's really unfortunate, because as we later on found out, and I finished my residency in 2006, we found out that actually at that point in time, we already had a lot of drugs. We had plenty of drugs for depression. We had plenty of drugs for schizophrenia. We had plenty of drugs for bipolar. Trying more drugs did not result in higher efficacy. It wasn't like, oh, I tried citalopram or Celexa, so that gave me, let's say, 40% chance. So now, after that didn't work out, I'm going to try adding Wellbutrin. So then that's going to give me the other 40% or another 60%. That's actually not how it works.
Yeah.
The more drugs you try, the lower your odds of getting the person better. Actually, each drug trial really is giving you somewhere between 10 and 20%. And actually, after a person is what we consider treatment resistant, at least in depression, in the case of depression, where they failed 2 medications, the third medication only has a 13% chance of getting that person to remission. And actually only after, and if someone had 4 different trials of medications, they have, I think, about a 68% chance of getting to remission. So can you imagine somebody tries 4 different medications, for really long trials, not like 2 weeks, where,
Yeah.
talking like 6 weeks in the clinical trial, in the trial that I was referring to, which was the STAR-D, the STAR-D trial. They started with 4,041 patients and 41 different sites, and the trials were like 12 weeks each. So some people went through all 4 trials and still didn't get better. All through 4 steps or 4 levels of treatment and didn't get better. And it's not a small number. I mean, you're talking about more than 30% did not get better after 4 trials. And unfortunately, the more you try, the more likely you are to have side effects. The intolerance goes up.
Yeah.
So
that's a very key point.
So you needed. There was clearly. I mean, so again, this data was published in 2006. So I was a resident then doing, a lot of ECT, and I was trying various things, but essentially it was very clear at that point in time already to the people that were reading the most literature, the people in training who were very
on
on it.
Yeah.
It was very clear that what we had was just not good enough. Even though we had over 20 drugs for depression, we still were not able to fix it. Now, since then, I will say that a different class of drugs has entered the market for depression. The antipsychotics have entered the market for depression. But you have to keep in mind that the antipsychotics are not drugs that we as psychiatrists are unfamiliar with. We have been using the second-generation antipsychotics, those 10 second-generation antipsychotics like aripiprazole and ceraquetiapine and olanzapine and risperidone. We've been using those first for schizophrenia, then for bipolar, and now we're using them for depression as augmentation. And we know what the problem is with those drugs. The problem is the side effects.
Yeah.
And no one wants to be, depression is so common. We're talking 15 million people in the United States per year are depressed. Per year, 15 million people are depressed. And treatment-resistant depression, you're talking around 7 million, like half of those people end up with treatment-resistant depression. Those people do not want to be on atypical antipsychotics. This is not like 1% of the population who has schizophrenia that you're trying to convince to be on a fairly serious drug that has serious side effects of high cholesterol, weight gain, maybe a movement disorder. This is a very enormous segment of the population.
Yes.
That many people don't want to be on these drugs long term, which is what we're talking about. So I had my eyes open. We have to find a different way to treat this population. So the only way that was available at that point in time was electroconvulsive therapy, which is efficacious but not tolerable. It's electroconvulsive therapy, which is the traditional shock therapy. You have to put the patient to sleep under anesthesia, paralyze them. And the reason why you're paralyzing them is because what you actually do is you give them a seizure for 25 seconds or longer, and you do this 3 times a week, usually for about 9 to 12 treatments, so 3 to 4 weeks, sometimes 6 weeks. Now, it's a very good treatment for people with treatment-resistant depression, but keep in mind, when you're giving someone anesthesia and then you're giving them a seizure, they can't drive. And they can't drive not just that day, they typically can't drive for a couple of weeks. They're having some significant percentage of them are having short-term memory side effects and cognitive side effects. So if you have, imagine treatment-resistant depression, imagine 7 million people a year that I tell you, well, if you give them another drug, it's just going to be a very low percentage of response and remission. You should send all of them to ECT. That would never happen because this is not an acceptable treatment modality for that many people. Only people that go to ECT are people that are really severe, that are basically going into the hospital, or almost going into the hospital. It's too much of a burden. They have to be driven. So what else was there going to be that wasn't working in the same way medication was working, but would somehow treat depression? So based on those initial nice pictures that I was seeing and the research in functional imaging that was being done, and really primarily by, at the time, by a guy named Mark George, who had started off at the NIH, but then was eventually and still is the chairman at the Medical University of South Carolina. He pushed the idea that you could see a relative decrease in blood flow in the left side of the brain compared to the right side of the brain in people that had depression or treatment-resistant depression. So he started with the idea of, what are we going to do to increase the blood flow to the left side of the brain? And he thought, okay, what we're going to do is we're going to stimulate the neurons in that side of the brain. How could you stimulate neurons? How do you stimulate neurons? Well, most of us know that neurons, or the brain is primarily an electrical organ. It's actually not primarily a chemical organ. In reality, it's an electrochemical organ. But when you, for example, say, think of something and then it happens, you think of moving your hand or some task, that message, the way it gets transmitted so quickly between thought and action, is because the message gets transmitted through an electrical impulse, which is traveling at hundreds of meters per second. So that's why it can move so quickly. So the way to stimulate a neuron would be through electricity. But in order to get electricity into the brain, you have to bypass the skin and the skull. And the way to bypass the skin and skull was already thought of by a gentleman named Charles Barker in England in 1984. And he invented the idea of transcranial magnetic stimulation, or he used Faraday's principle of induction, of inducing an electrical current by using magnetic pulses.
Okay, stop right there, because I know now. Could you just take a moment to elaborate on that whole thing? Because that's a deep. You just kind of jumped off the cliff right there. So let's go back to Faraday's this whole thing of the principle of, and repeat that. I'm unfamiliar with it. I know my listeners are.
Okay, so Faraday discovered the idea that you could induce or generate a current in a wire. For example, if you wanted to turn on a light bulb, okay, you need a current to go in the wire. If you want to induce a current in a wire, okay, without obviously taking another wire with current and attaching it to it, you could induce it using pulses of magnetism. Okay. If you use magnetic pulses, magnetic pulses will induce a current in an underlying conductor, and something that can conduct electricity. Okay.
Very interesting. Yeah.
And that was something that Faraday discovered. And when he discovered that, he actually started his research notebook over from page 1, because he realized that that was a monumental discovery. Okay. I mean, and there's some more details to it which go into the actual design of the magnetic coils, right? But in reality, that's the main point.
Got it.
If you take a magnetic coil and you move it back and forth, back and forth, back and forth over a conductor, so you're generating pulses essentially of a magnetic field, you are inducing a current in that conductor, in that wire.
Very good. Very interesting. Yeah.
So what Charles Barker did in England is that he created a stimulator, or transcranial magnetic stimulator, that could cause individual pulses, individual magnetic pulses, and he put it over the motor cortex, the part of the brain that's responsible for motor movement. And the person would hold in their hand, let's say hold in their right hand, the magnetic coil, put it over their motor cortex, like on the top of the head, but above the ear, not all the way up to the top of the head, so somewhat above the ear. So they would hold like a butterfly or figure 8 shaped coil, magnetic coil over there. There'd be a click from the magnet discharging a pulse, and that would cause the arm or the hand, specifically the finger, contralateral on the opposite side, to twitch. Because, for example, the right side of the brain controls the left hand. And that was how he used magnetic pulses to stimulate the brain by bypassing the skull and the skin. Because the skull and the skin, they don't have any conduction. Okay?
Right.
And now, if I was to take direct electricity at a strength that was high enough to induce a current, to try to get that onto the brain, I'd have the skull and the skin in the way, and it would be very painful. Okay?
Gotcha.
It's very painful. When we do that, for example, with electroconvulsive therapy, to induce a current in the whole brain, we have to put the person under anesthesia, because it's a very painful experience otherwise.
Yes.
So in this case, what we do is we are not using a very painful stimulus, because we're bypassing the skull and the skin, and we're using a very brief magnetic pulse. So this field of transcranial magnetic stimulation has evolved because of two things. Somewhat because of our understanding of the targets that we want to apply our technology to. So if we have a target in the in the brain that we know is responsible for depression, that's good, because then we can treat depression. If we have a target that we know is responsible for anxiety, we could target it for anxiety. If we have a target for addiction, that's great. If we have a target for Parkinson's, that's great. If we have a target, and I could go on all day for this. But
the bottom line, let me stop with the targets, because you're talking about anatomical targets. I just want to clarify that, because what's happening is it's a switch in thinking, just like you did with the brain and the contralateral thumb or whatever. We now have, through brain imaging and through a variety of research, specific places that these things take place in the brain. And then if you know that, then what you're saying is you could go in and actually target that and identify that and go after that specific anatomical area.
Exactly. So that's one component that advanced the field, okay? Because we needed to have more and more science about which anatomical targets to approach. The other thing that advanced the field was technology, because everything has been limited all this time by our ability to get appropriate stimulation to the target. And when I say appropriate stimulation, the right dose, the right intensity, to the right depth, in a specific period of time, in a tolerable fashion. So the technology has also been the second factor that is correspondingly. So basically you have a field of engineering that's or physics and engineering that is progressing along with the field of neuroscience. And those two fields come together and help us treat patients with diseases of the central nervous system, specifically psychiatry and neurology.
Yeah.
So to be able to use transcranial magnetic stimulation, you have to have some understanding of all of those fields.
Fields and brain anatomy. You've got to put the whole package together to do it effectively. You can't just go ahead and take a shot at it like we did with ECT. I mean, I was doing ECT back in 1968. So, I mean, that's a very interesting point, because you think about you being a younger guy than me. You're coming in doing ECT as kind of the state of the art, and yet the next step all of a sudden walks in your door, and you begin. How did you actually get to the discovery, the connection with that level of training? Was that in Chicago or was that at Tulane? Where did you become familiar with it?
So let's keep in mind that I think that you can do this as well, okay? And the majority of the doctors that are doing this learned all of this after they finished their training. It's all stuff that you have to keep learning on the job. Most psychiatric professors at the universities, and most universities, do not even have the technology.
They don't understand it, yeah.
Well, they don't have access to it, so it's harder for them to understand it.
Okay.
I'm not saying that universities don't have it. I'm saying most universities to this day are limited with the amount of technology that they have. And the reason why they're limited with the amount of technology they have is because this is, if you think about the structure or the way things are set up, you really need some source of funding to put all of these things together. So the field is also tied or hampered a little bit to some degree with funding. So you need to bring people in from multiple fields to work this together. So actually, I came about this. I was aware of this, in the far horizon when I was still in the University of Chicago. I mean, transcranial magnetic stimulation has been under research since the 1980s. Mm-hmm. Okay, but the limiting factors have been technology. Like, they couldn't make a stimulator that could reach, get enough pulses, get deep enough, that could be cooled down. Okay. So you asked about some of the acronyms. So repetitive, rTMS means repetitive transcranial magnetic stimulation. And typically that refers to conventional, or the butterfly-shaped coils, okay, that reach a very small distance beneath the surface of the brain or beneath the cortex, and therefore, if you think in the prefrontal cortex or if you think over the motor cortex, the distance between the skull and the dura and the cortex is about 16 millimeters, like just about 1.5 centimeters. Okay? The total amount that these magnets can get, at best, is less than 3 centimeters, about 2.5 to 3 centimeters.
Okay.
Okay? Meaning their electrical field that they can induce, meaning their magnetic field, and then subsequently the electrical field that they will induce below that will not be sufficient to depolarize a neuron or to move a muscle.
Yeah.
Theoretically.
Yes.
You would need to put on a stimulator with a tremendous high power, tremendously high amount of intensity, and that would eventually cause a lot of pain or heat up the stimulator or break it. So conventional TMS, okay, though, was the first TMS that was approved, and it was approved with a very small margin of efficacy in patients that were on no medications, meaning as monotherapy, and they had really only failed one antidepressant. Not patients that had failed any number of antidepressants, just patients that had a lower degree of resistance.
And that's the rTMS now. That's the elemental early one.
But rTMS is an acronym for repetitive transcranial magnetic stimulation. But when we say conventional TMS, conventional rTMS, we're referring to devices that are made, for example, by a company called Neuronetics, a company called Magstim. Magstim has been around for a long time. They've been making all the research coils for years, okay? A company called MagVenture, okay? Those are all the conventional transcranial magnetic stimulation coils, okay? Now, the company that makes a different coil is called BrainSway, and they make a deep TMS coil. Okay?
How could you spell that? I'm taking notes here while you're talking. What was the name of it?
BrainSway.
SWAY?
Brain, BRAIN, sway, SWAY.
Yeah, got you.
Okay, BrainSway. Now, so I'll tell you a little bit about the history of how I came into this. So in 2008, in October of 2008, the FDA approved the first conventional TMS device for depression, and that was the NeuroStar. And I had immediately gotten a device in January of 2009, and I treated patients with it, and I had some pretty good results, particularly if I gave it to patients in combination with their medications. And they really put, that company, NeuroStar, really put TMS on the map in the United States. And they started the battles for that helped with reimbursement and things like that. But there was some limitation because their magnet couldn't reach very deep. And their magnet is a magnet without a cooling system. But the main issue has been depth, and it's a very focal stimulation, and it doesn't get very deep. And essentially, because of that, there's sort of a ceiling to the efficacy that treatment could get.
Understood.
So while I was still treating patients with those devices, and I had two of them that I was using in two of my offices, I started to do research with a company with BrainSway, and I started with the depression clinical trial with BrainSway. And their helmet it's a helmet. Their magnet comes in a helmet, and the reason why it comes in a helmet is because it's many wire windings that are in several different planes. So the actual magnet is larger than the person's head, and the magnetic fields sum together to reach much deeper. Technically, if you were starting from the top of the magnetic field can reach 6 centimeters. Looking into the skull, beneath the surface of the skull, the currently approved depression magnet reaches 3, sometimes 4 centimeters beneath the surface of the skull. So you have a magnet that can reach 3 centimeters beneath the surface of the skull. So that is much, and 9 centimeters wide. Okay? So you have a very wide area of stimulation.
Mm-hmm.
So you're going from something that was stimulating 1 centimeter in a very narrow, basically nickel-shaped area to something that's stimulating 9 centimeters, and it was actually stimulating both sides, the left more than the right. And there was a dramatic difference, specifically a dramatic improvement in the efficacy when you started to use deep TMS.
Okay, now stop right there. Let me ask you this question.
Do
you actually target like the limbic system? Do you have in your mind when you're working with somebody, this is where you're going, or what's in your mind anatomically when you're thinking 6 centimeters? What do you think that way, or is that inappropriate?
Well, let's get to that in a second. So when you're targeting the specific person, you're really just trying to think of either one of two things. You can either think, what is this person's disorder? And therefore, in a simplistic way, this person has depression. This is a coil or a helmet that's approved for depression. Okay?
Mm-hmm.
And I'm going to do that. Or you could think, what are this person's symptoms? And where in the brain is this person's symptom orient coming from?
Yes.
So when you come to that point, for example, so if you say to me, oh, my symptom is depression, not my disorder is depression, but my symptom is depression.
Yes.
My symptom is sadness. Or another person will say to me, my symptom is rumination. I'm obsessing. I'm ruminating. Well, I'll say, oh, maybe that comes from the medial prefrontal cortex or the anterior cingulate cortex.
Yes.
I think you need to target, in your case, I need to target a little bit more medially and a little bit deeper.
Yes.
Okay. So when a doctor is thinking about how to treat a patient with transcranial magnetic stimulation, they could just say, I just treat people with a certain label that are with the specific coil, and that's really how we expect people to be at this moment. But because right now the FDA has only cleared several different devices for the treatment of depression, okay? As far as the current state of...
You mean when you say devices, certain coil wraps, certain head, certain...
magnets.
Yeah,
several
certain magnets, yes.
Specifically the magnet from Neuronetics, the magnet from MagStim, the magnet from MagVenture, the magnet from BrainSway.
Oh, I got you, okay.
Right now, the FDA has just approved several coils for the treatment of depression. And you could say, as a doctor, that's the way I think about it. I have several devices, options. There's a clinical trial, that Neuronetics had 2 clinical trials. BrainSway had 1 clinical trial. The efficacy results are as follows. This is how I'm going to treat the patients.
Gotcha.
But you could also be, the reason why, I think the reason why you reached out or you were interested in sort of all of the clinical trials that we're doing here and sort of the way we orient ourselves in the future, okay?
Yes.
The way we orient ourselves in the future is we're thinking about a future role of what we consider maybe an interventional psychiatrist, where we don't think about just depression in one device. We think about, oh, you're a person who has symptoms of depression, but you also have a lot of symptoms of addiction, and you also have maybe some Parkinson's. So in your case, I'm going to target this and this and this area.
Yes.
So it's a little bit of a different orientation. That's not where the market is just yet, but that's where the direction that we're going in.
Okay, let me translate that for listeners. So what you just said, correct me if I'm wrong.
Yes.
What Dr. Tendler said is that the whole situation is changing, even where he is right now with his advanced level of thinking, that the evolution regarding the complexity of brain targets is actually improving, so that there are specific treatments for a diversity of targets as opposed to where you were just a few years ago where the diversity of targets wasn't quite so appreciated. Is that correct?
That's correct. And I want to say, I want to make another point clear because we didn't discuss it in the opening. So I started doing research in 2010, and the BrainSway was approved in 2013, and that's when I started to use it commercially. And I became their chief medical officer in 2015. So I'm a little bit more aware, and I'm a little bit more of an advocate for them even now. But I think there's even a further future direction that I haven't, discussed yet with you, which is that neuroscientists know that although our current technologies are still focused on treating one target at a time, so for example, if I was going to treat depression on the left prefrontal cortex, mania on the right prefrontal cortex, attention deficit disorder on the right prefrontal cortex, and OCD on the anterior cingulate cortex, and PTSD on the medial prefrontal cortex, and addiction on the bilateral insular cortexes, okay? All those are taking into account that I'm doing only one target at a time. Oh. So maybe I'll give 2,000 pulses, and then I'm going to move to this area and do 2,000 pulses or 1,000 pulses, or some sort of parameters. But actually, we know that the normal brain doesn't function with one target at a time. So there's this idea of networks in the brain. The brain functions via networks.
Yes.
So when I actually look even at a resting brain, I see we call the default mode network or the non-task network. And when I look at a task network, when I say, okay, I want you to think about remembering something or to think about throwing something, I don't just see activity in the area which is responsible for my hand throwing a ball. I also see activity in the other side of the brain and in multiple areas of the brain. And it's all occurring at once. So when we think about, how are we ever going to get in psychiatry to the goal of treating 100% of our patients to the point that they're well, as opposed to a good treatment being one that gets 50% of our patients well. Yes. I think that goal will only be reached using a technology that targets multiple networks at once, because we have to renormalize the networks of the brain. Like, we are thinking about the disease of depression or the disease of Parkinson's, for example, which isn't a psychiatric disease, or the disease of Huntington's or the disease of Alzheimer's, as the disease of obsessive compulsive disorder, as a disorder of connectivity, of where there's an imbalance in multiple areas, because as soon as one area is not operating right, the other areas are not going to operate the same way. So we have to renormalize the circuitry through stimulation in multiple areas. So the technology that we're working on is not even out yet. It's got to be a technology that can target and I have to be able to inhibit and stimulate and inhibit and stimulate maybe 5 targets at once.
Very interesting. Very, very interesting. That's and I really appreciate you sharing that with us, because it's so interesting. It's sort of, we're doing the same thing over here. I don't do transcranial magnetic stimulation by any means, but from a biologic point of view, that's where I've been, but from a different perspective. And you did say a moment ago that there's an opportunity for a confluence of using different support systems for those brain networks. Yeah, maybe meds would help a little bit, but these targets that you're using actually amplify whatever might be going on with other levels of intervention. Do you use medication with this, or do you not use medication?
So as a general rule of thumb, we don't stop medication, and the rates we know in open label, not just with my office, but everywhere. Whether you're using the conventional rTMS or the deep TMS that's wider and deeper, literally the rates are double if you're using medication with the TMS versus if you're using the TMS alone. So if a patient comes to you and says, my Paxil's not working, okay, well, I'll tell you a secret. It's doing something, because if you take that Paxil off, it lowers his response by about half of what it would be.
Very, very interesting. That's interesting. Now, let me ask you another question, because you mentioned a lot of really difficult diseases to treat, or conditions, not diseases. And, you even mentioned cigarette smoking in the intro. But one of the things that's troubling me in my own professional work is, what does one do with tardive dyskinesia? Is that something that this kind of a intervention system might help?
Yes, there's one. Part of my. So you asked how you learn. How did I get to this? Right. So
Yeah.
I've been the combination of self-taught and taught on the job by the various companies that I bought the technology from, and by the conferences that I go to every year, and by courses that I go to, that are offered at various institutions.
Mm-hmm.
So I went this year to a course, and it was an excellent course. And at that course, it was a 1-week course on transcranial magnetic stimulation. And to give you an idea, I went, after doing TMS from 2009 to 2016. I went I took a 1-week course on transcranial magnetic stimulation.
Wow.
And I still learned. I still learned some new things. It was an excellent course. It was given at the Beth Israel Deaconess Medical Center, and there was a psychiatrist there who was from Monaco in France, and he had been doing TMS for 10 years. It's amazing, when there's money, sometimes amazing things can be tried. And in Monaco, the psychiatric hospital amazingly has money. Mm-hmm. So he had treated already 2 patients. He didn't know long-term outcomes, but he had treated 2 patients with tardive dyskinesia using an inhibitory protocol. So I've only just mentioned the idea of stimulating, but depending on the way you use the magnet or the pulse sequence that you do, you can actually also inhibit neurons. So he had used an inhibitory sequence over the supplementary motor area, and he had treated tardive dyskinesia in 2 patients. And he had seen some short-term benefit, and he was eager to keep track of those patients for a year. And if he would see a good benefit, he was going to publish those case reports.
Very interesting.
That's something that was very interesting. Yeah.
That is totally interesting, because that's one of the major refractory areas. I mean, all these things are refractory, just as you said in your introduction, because we're not doing it right if we're only covering a portion of whatever. If we're only collecting neurotransmitters with medications, the mind is far more than just the simple neurotransmitters or transmitter receptors. When you get into the genetics, there are a whole lot of other things that are taking place to balance the brain out effectively. And I'm looking at our time, and I'm a little bit concerned about winding up here, because I'm enjoying this conversation so much. I'd like to continue the conversation at some other time. Let me wrap this a little bit with you, Aron, and ask you this. And you said a little bit about it, but what do you envision the future will be for our listeners who are interested in where this is going? You said a little bit about it, but what do you think is going to happen to psychiatry in this and mind science?
Well, the direction psychiatry is going in is typically there's a combination. If you look historically on the evolution of how SSRIs kind of took over from tricyclics, okay?
Mm-hmm.
Which, it took about a period of 10 years after the SSRIs came out until the prescriptions really came up. So even though SSRIs started coming out in the 80s, it really was till the later 90s when there was a really large volume increase compared to the tricyclics. So if you think of transcranial magnetic stimulation, really just because, or certainly transcranial magnetic stimulation was approved in 2008, but deep transcranial magnetic stimulation, which has actual real clear efficacy to people in the field, only came out in January of 2013. So I think people will adopt it more and more and more over the next 10 years, and there'll be more and more, as people use it more, there'll be greater reimbursement. And it's sort of a field that has to grow through the companies that are manufacturing the devices, because they need the money to improve the technology and to fund the multi-site clinical trials.
Mm-hmm.
So it's sort of a field that's going to probably grow over the next 20 years in an exponential fashion.
Mm-hmm.
Because as the adoption goes up over the next 7 to 10 years, that's when many more people will be exposed to different indications. Now, if I tell you, hey, I want to put a magnet on your head, and then I'm going to try to get you to see if you're interested in smoking, and then instead of letting you smoke, I'm going to turn on the magnet, and that'll satisfy your cravings. You're going to think I'm talking to you like I'm the schizophrenic.
Yeah,
right. But in a year or two from now, after all your neighbors have tried TMS for depression, you'll be like, hey, maybe that makes some sense.
Yeah.
It'll make some sense to you. Just like probably didn't make any sense to take Wellbutrin to quit smoking. Why would you take a pill to quit smoking? What does one thing have to do with the other?
Yes.
So
yes.
These things will take a little bit of time, and I think that's where we're going with that.
Well, Aron, I'm really regretful about winding this up. We're going to talk again somewhere down the road. You have done a very, very good job of bringing some difficult subjects right into, wherever anybody is listening, whether it's the gym or in their car going to work. You've said a lot of really important things to people that will help move the needle forward. There's no question about it. And I want to express my appreciation for that. By the way, listeners, Dr. Tendler's also hooked us up with a PDF, which is going to be downloadable. He's going to be, and if you go to corebrainjournal.com/003 download, you'll be able to get Dr. Tendler's PDF, which will have some links and some other information that will take you further down the line with this very interesting information. So thank you very much again, Doctor. I appreciate you taking the time. It's very, very interesting. We're going to have you back. Any closing remarks you have?
It was nice to meet all of you. Thank you.
Thank you very much, sir. You have a great day. Thanks for listening to Core Brain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at corebrainjournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.